Hello, my name is Liz Hunter and I'm the CEO of Westgate Health Cooperative, and I'm delighted to welcome you to the first of our community mental health forums for clinicians and GPs. I would like to open this forum by acknowledging the traditional owners of the lands, the many lands upon which we will be meeting today, who sustained healthy communities and wisely managed these lands for thousands of years. We pay respect to their elders past, present and emerging, as we at Westgate Health remain committed to shaping a future in which all thrive. I would also like to extend a warm welcome to any First Nations peoples who are joining us at our forum this evening. So how did these forums come about? Westgate Health has a long, proud history as a not-for-profit, member-owned cooperative that provides excellent, affordable health services to its members. Located in South Kingsville and Newport in the western suburbs of Melbourne, we've been here for around 40 years. We provide GP and allied health services in a caring, compassionate, patient-centred setting. And we typically retain our high-performing staff and patients for many years. As a not-for-profit, all of our profits go back into caring for our community. We offer services across 2 sites in South Kingsville and Newport, and our GPs meet up each month. They all practice medicine in their own unique way, and they deeply care about the patients they see. Like many of you, they know where the fractures are in the system, and they experience these firsthand. As we're a not-for-profit cooperative, we're also a voice and a community leader when it comes to primary health. This week, for example, we're hosting these forums, and next week we've been invited to speak at a Senate hearing into GP services in Australia. So last year, when we received a generous grant from Westgate Neighbourhood Fund to run this series of community mental health forums, we went to discuss with our GPs which topics they would like for the forums. And the first thing they asked is, could we have a session for clinicians about navigating our mental health system, which is how tonight came about. Dr. Ben Chia, who is with us here tonight as our facilitator, came to that meeting and in conjunction with Westgate Health helped to form the vision for this program, and that's where it all started. Westgate Health Cooperative loves to connect with like-minded clinicians like Ben, who want to provide services in a flexible and supportive work environment and who can enhance the health and well-being of our patients and community. If you or anyone you know are curious about how we could connect or what it is like to be a clinician at Westgate Health, please call our clinic to speak to myself or send an email to our address on the website. It is our very great privilege to now launch the first in our series of 5 mental health forums. We are delighted to co-host these forums with Ben and have a great lineup of presenters and topics. We are incredibly grateful to Westgate Neighbourhood Fund for their generous donation, which made it all possible. And a special thanks to MP Melissa Horn for her ongoing interest in our cooperative and this program and for her support. Now, in terms of some housekeeping, this forum is for you, the attendees, and we're so grateful that you're here tonight. So we really encourage you to ask questions today via the Q&A function on the right-hand side of your screen, and we will ask those questions during the panel discussion. If you have any technical difficulties, please refresh your page, or you can chat to our events team via the tech support button on the bottom right-hand side of your screen. Thanks so much for attending. I hope you feel very welcome and take away information and inspiration that will enhance your clinical practice. Westgate Health Cooperative is a not-for-profit community health organisation that's been around for around 40 years. The project that we're about to launch into is a community mental health project, and we see this as an opportunity to meet the needs of many people in the community by empowering them to find their own way through the mental health system.
Mental health has always been a common theme for GPs in terms of people who they're dealing with. During the pandemic, all the mental health problems that people have had have got greater and more intense, and what can we do to help people to find their way through this, to be able to access resources that are there, and to do this in a community collaborative way of itself is bringing people together. And some of that networking, some of that people working together, problem solving together, is of itself going to be helping people find their way through this.
We're a really diverse community, and it's an opportunity for people to have their needs met where they're at, and that's what we see as being hugely beneficial, because that's it's not one size fits all, and that's the challenge for our GPs as they work their way or guide people through the system as to what's best going to meet their needs.
So we couldn't have done this without the funding, and we're just so thrilled that we actually are now being able to get funding that we can put this program on, run face-to-face sessions for the community. It's a game changer for us. We just simply would not be here having this conversation if it had not been for the grant that we received from Westgate Neighbourhood Fund.
Hello, welcome everybody to tonight's forum on navigating the mental health system. I'm Ben Chair, and I'm a consultant psychiatrist in private practice, right next door to Westgate Health Co-op in South Kingsville. Obviously did all of my training through the public mental health system and my early career as a psychiatrist in the public hospitals, and then gradually transitioned to full-time private practice. So I've sort of got a view of both sides of the fence, and this has always been a topic that I've thought has been one that's poorly understood by a lot of people working in the system, and I was really grateful to be given this opportunity to facilitate this discussion tonight for you all. So obviously I think it's a really good time to reflect on what's been a whirlwind 2 years of this pandemic and going into a third, and really it's caused an unprecedented rupture and fragmentation of our communities, and in particular people's support systems. Obviously we weren't prepared for either the physical effects of the pandemic, but the so-called shadow pandemic that is talked about in terms of the effects on mental health and well-being. And that's not only for patients, I think, but also for us as professionals, juggling the effect of the pandemic on us and our patients, and the extra stress that brings. And I know that I feel like I was in survival mode for a lot of that, and I'm sure everyone else has felt that as well. And all of this came hot on the heels of the Royal Commission into Victoria's mental health system and their recommendations. So really didn't get to take a breath between that and the pandemic starting. But just a couple of things that the Royal Commission found that is relevant to this discussion is in 2019 to 2020, the system responded to less than 1/3 of the demand for community mental health services across all age groups. And that's just in clinical services, not just, only clinical services, not the psychosocial side of things. And that the public system had a shortfall in terms of the demand for services and what was actually available of 3.3 million hours in 1 year. So as Liz said, this topic came about at the request of GPs in the local area, who found it really difficult to know what options were available for their patients and how to access them. I know that being the psychiatrist in my family and my friendship group, that I get a lot of questions about how to navigate the system from all kinds of acquaintances, whether it's friends of friends or family. And that has gone up exponentially during the pandemic. And unfortunately, I often don't have a good answer for people when they ask for my help, even if I try and pull strings, because the system is under a lot of stress. So hopefully this forum will make things a lot clearer and give you a template to at least have the best chance of finding the best care for your patients. So this is a flowchart that I developed with Westgate Health, trying to actually get a picture of what the system looks like. You can actually download this from the page at the bottom. If it's not there now, we'll make sure that you can get access to that. But what it really shows is that I'm not going to talk to this at the moment because our speakers are going to do that, and then we're going to have a discussion about it. But what it really illustrates, I think, is that it's a fragmented puzzle with lots of gaps. You can see there's a lot of back and forth, and people do fall into those gaps. And I think sometimes that's when crises occur and risky situations occur, and that's when I often get involved, but also sometimes there's just not the services for those people. So I think this chart could be arranged in lots of different ways. You could arrange it into public and private services with the primary health network and the NDIS feeding into the private side of things. But I think the biggest gap is between public and private, and I think a lot of the discussion tonight we'll have a look at that. The box that I've circled there was this old, what was called Mental Health Community Support Services, and before that it was called the PDRSS sector. And this was made up of a lot of NGOs like NEMI, Mind, CoHealth, and one of my favourite, I guess, programs in those services was FAMS, which was Personal Helpers and Mentors Service, that would allocate people with a mentor, and this would complement the care that I was providing. And mentors could go out with people, help them with integrating into society, doing things that they found challenging. But when NDIS came in, I think a lot of those systems got fragmented, and some of the FAMS program actually got disbanded. And I sort of vividly remember some of my patients suddenly just losing their mentor because of a change in the system. So it'll be interesting to see where those, because I know those organisations are still around, and it'll be great to hear how they're going to reintegrate back into the system. So now we're going to move on to our first speaker, who is Dr. Dean Stevenson. Dean completed his undergraduate medical degree at the University of Witwatersrand in Johannesburg, South Africa, before going on to complete his Master of Medicine in 1994. He's a fellow of the College of Psychiatrists, and in 2002 commenced at Mercy Health and Aged Care, consulting to the community treatment programs and community care units. His current role is Clinical Services Director with oversight of mental health services across Mercy Health, commenced in 2005, whilst he is also Clinical Associate Professor and Psychiatry Discipline Lead, University of Notre Dame Melbourne School. So it's my great pleasure to introduce Dean, and obviously he has the best view of the public system, and thanks very much, and we'll talk to you after.
Thank you, Ben, and good evening to everybody. It's thank you very much for the invitation, and it's great to be able to speak to you tonight. What I thought I would do is provide you with an overview of the impact that the recommendations arising from the Royal Commission are going to have on service provision in the western suburbs. You would all be aware that the recommendations were very lengthy, very dense, composing of approximately 5 volumes. So it's certainly not my intention to go through every recommendation that the Royal Commission came up with, but I'm just wanting to speak a little to what changes you may see in in this catchment area. Now my slides have jumped forward and I can't get them back. Just give me 1 sec. There we are. Thank you. Thank you very much. So again, I'm giving you a very broad helicopter view, and I'm going to focus on the risks and opportunities and the challenges which we all going to face as a community providing care to the Western sector. So there's name changes for a start. We've always been known as an area mental health service, and we will become in the future an area mental health service. Area mental health and well-being service. So that's a little change there. One of the biggest changes you're going to see is the change in the catchment areas. Now, I'm sure if you've been practicing in this region for a while, you'd be well aware that area mental health services work very much to catchments, and referrals to those services depend very much on the person's address. Now, that hasn't changed terribly much with the Commission, although there is a drive for people to choose wherever they would like to have care. Southwest Area Mental Health Service, or Mercy Mental Health as we commonly known, used to provide services to the city of Maribyrnong, Hobsons Bay and Wyndham. So in the recommendations coming from the Royal Commission, we lose Maribyrnong, the city of Maribyrnong, and we become a service that provides clinical psychiatric services to the city of Hobsons Bay and Wyndham only. The city of Maribyrnong moves to Western Health, which is a new area mental health service in this region, and they will also take up the services of Midwest Area Mental Health Service, which is predominantly the Sunshine area. So those are fairly big changes that you're going to see. I won't talk to the changes happening in the Northwestern mental health area, but suffice to say that there's this disaggregation happening across that broad service as well, with the establishment of another area mental health service, independent area mental health service with Northern. Governance is also going to look very different. At the moment, the governance of area mental health services sits with hospital networks. The Royal Commission has established regional boards, or is in the process of establishing regional boards. And we're not exactly sure how this is going to fit at the moment, but it appears that there's going to be a dual model governing mental health services, the hospital network, as well as these regional boards. We are also changing in the age range. So at this point in time, Mercy Mental Health provides services to people aged 16 to 65, with the rider that people have their first episode of care with Origin and then are transferred across to Mercy Mental Health. This has changed, so we will no longer be a service providing any care to people between the ages of 16 to 25. We will only be providing care to the people 25 years and above. We will then also take on older person psychiatry, so in other words, 25 to pretty much to end of life. The 0 to 25 will be managed by Origin and Royal Children's. We've had a problem with the slides there. Oh, there we are. Thank you. So what about resources? So obviously with desegregation comes the shifting of resources. And that's clearly going to have an impact on services who are dividing up versus those services who haven't had any of these impacts. We're also not clear yet what's going to happen with the funding. If we're losing a chunk of people that we're providing care to and gaining more people that we're providing care to, how is this funding going to be shifted between services? We're also going to experience a reduction in our inpatient bed stock. At this point in time, we provide services to Footscray Hospital and have an inpatient unit based there. With the disaggregation process, that unit moves across to Western Health, and we retain our inpatient unit at Werribee Mercy Hospital, and those will be the only inpatient beds that we have. So our bed stock falls from by a fair number down to 54, from about 79 to 54 beds. So that'll be a fair challenge for us. The other issues, of course, is planning, capital planning, master planning. We're going to lose a big clinic in Footscray Hospital. Where are we going to base our other clinic? Where are we going to find resources? Our prevention and recovery care unit, which is a step-up, step-down facility, is located out of area, and we're going to have to try and find a site for that within our area. So what are the risks? I've touched on a few of the risks in providing you with an overview. But one of these are particularly the risks facing our mental health service, which is the service which, if you're in this catchment, will provide psychiatric services to your patients. With the focus on all the reforms and the disaggregation, is a lot of our time and energy is being consumed by that alone, and there's not that much space to focus on the reforms and implement the reforms. Local inferences as well is the timelines is a challenge because we're not 100% sure yet exactly when all this breakup of services is going to occur. We suspect that it's going to be some of it in the Northwest region will happen in the middle of this year, but it's likely that our disaggregation process will happen later in 2023. Of course, the big risk as well is when a service is a little unstable in terms of its area and its catchment. There's a big risk, and we're already starting to see that happening, of you losing experienced staff and those staff moving across to services that are a lot more stable. We are seeing that already, and we've lost a number of senior staff to area mental health services in the eastern suburbs. The other challenge, of course, is the geography. We are shifting out further west, which may make it a little more difficult to capture people wanting to work with us. They're likely to look more urban than peri-urban. So that is that's one of the complications that we face as well. But with change, and change was certainly needed, as I'm sure you've experienced. There's always been, as Ben noted, huge gaps in service provision. There are opportunities, and I've just listed a number. I'm not going to go through every one of these opportunities, but I think probably the major opportunity, and this comes on the back of some recommendations from the Royal Commission as well, is the working in partnerships. We've talked the talk, but we haven't been able to walk the talk. So we are hoping that as these reforms start stepping in place, there'll be much more collaboration between the general practice networks, between the community mental health support services and clinical services, because we're going to need these structures to provide all the services that the Royal Commission is wanting us to provide. We also have the opportunity now to develop more services. Drug and alcohol has been a big problem in that it's been a very separate service to public mental health services, and there'll be a strong move to integrate drug and alcohol services within clinical services. So that's a promising move. And of course, we are now going to start, we're going to have to develop a program and a model of care around service provision to older persons, which is something that is that's very new to Mercy Mental Health. And again, just touching on people, one of the positive changes about having a much smaller catchment area and losing an acute inpatient unit is that makes our medical structures of on-call much simpler. We don't have to provide 2 on-call rosters to cover 2 acute inpatient units. So in terms of Mercy Mental Health probably has one of the highest on-call rates of any of the area mental health services in Melbourne, and that does impact on recruitment. So that's a very positive change. And obviously, we're going to have to find experienced people to present to enable us to provide the services that the Royal Commission is wanting us to do. And of course, the growth, the opportunity for growth for clinicians within area mental health services now will, I think, be much more than the current more narrow focus. Opportunities, I've touched on the importance of partnerships. So just to reiterate that again, speaking with the aged care services at Northwestern Mental Health, they have a very well-established model of involving general practitioners in the care of the older persons in their psychiatric services. This is something that we would like to look at. So programs with general practitioners will be very important in that. We're also in the process of developing a community-based consultation liaison service to general practitioners in the community. I don't know whether you may remember the good old-fashioned primary mental health team, which sadly disappeared when funding was so drastically cut from mental health services over a number of years. So again, very important partnerships that we can develop there. I'm on to my last slide now, and I just want to touch on some of the challenges that we're going to face in implementing these recommendations and getting up all the services that we need to get up. In my view, the critical shortage of skilled mental health clinicians, and that's including junior medical staff, senior medical staff, nursing staff, occupational therapists, psychologists, is a very big stumbling block. To give you an example, I have some positions in both inpatient units that have been vacant for a year to 18 months, just unable to recruit people to those positions. And that is a big concern of all of us, is to find the right staff to provide those services. Unfortunately, the complexities in service provision to the 0 to 25-year-old age cohort remain. So Origin and Royal Children's Hospital continue to provide those services. And I'm sure, as you're aware, that this causes a lot of confusion in referral processes and who's following up people. So unfortunately, the Royal Commission has established these as independent services, but hasn't incorporated it into a whole of age service. The other issue, which I touched on a little earlier on, is where are we going to find a suitable venue in either Hobsons Bay or Wyndham to house 150 clinicians when we lose Saltwater Clinic. So, at the moment we're spending a lot of time with real estate agents trying to find suitable accommodation. And then, of course, finally, I just want to touch base on the new Mental Health Act. I'm not going to talk to it. It will be known as the Mental Health and Wellbeing Act. The timelines were extraordinarily tight, and it was initially recommended that the new act should come out in July of this year. That's now been pushed out to July of next year, but that's going to bring with it a number of challenges in terms of getting staff accustomed to the new ethos of the new act, and getting everybody understand how we might work under the act. So I'm going to leave it there. Thank you, Ben.
Thanks very much, Dane. Sounds like a big job that you've got ahead of you, and hopefully you get the funding you need to deliver on all that. And we're now going to hear from Stephanie Brophy. Stephanie is the clinical lead for the mental health intake service at the North Western Melbourne Primary Health Network. This includes the Care in Mind and Head to Health programs. And Stephanie is a mental health nurse by background and has previously worked at the Northwest Mental Health Service. Thanks, Stephanie.
Thank you for this opportunity. I'm really excited to talk about the Northwestern Melbourne Primary Health Network and our role in the mental health service sector. We're really proud of our work and looking forward to talking about that tonight. So tonight I will talk about the Care in Mind service, the Head to Health program and the IAR tool, so the Initial Assessment and Referral Decision Support tool, and what they are all about. So before I go into our mental health programs, so our region covers most of central, western and northern Melbourne. We have two of the fastest growing suburbs in Victoria, which are Wyndham and Melton. And the region contains some of Victoria's most socioeconomically disadvantaged areas, where there are elevated indicators relating to poor mental health, including high unemployment and high levels of social isolation and psychological distress. Our system of care. So our system of care provides supports according to specific needs. We aim to improve access to mental health services for people who can't easily access them and for priority populations. The Care in Mind and Head to Health programs are part of our system of care. And at the PHN, we operate the intake services for both the Care in Mind and Head to Health program. So now I'll talk about the Care in Mind service and the suite of programs. So Care in Mind offers free mental health support from low intensity to severe mental health concerns. The wellbeing service, so that's operated by On the Line, and anyone can contact the wellbeing support service and access up to 3 free counselling sessions. So a referral is not required. So anyone can call that service and access support over the phone. The Targeted Psychological Support, or TPS, is a free counselling service for low-income earners and priority populations. A referral is to be sent to our intake service, and people can access up to 12 free counselling sessions. We contract mental health clinicians across our region to deliver these services. The Intensive Support Service, or ISS, is for people with severe mental illness, and again, a referral is to be sent to our intake service. People can access support by a mental health nurse who can offer care coordination, psychoeducation, mental and physical health assessments, and there are no limits on sessions, so it's more of a flexible approach to meet the individual's needs. And the Suicide Prevention Service, that's also operated by On the Line. So referrals are to be sent to On the Line. It's of course for people at risk of suicide or self-harm, and who are not eligible for area mental health services. The client will be called by On the Line within 24 hours from receiving a referral. They will complete an assessment with the individual over the phone, and then assign them to one of the contracted mental health clinicians. up to 8 sessions over an 8-week period is available through that service. So here are the contact details for the Care in Mind service. Currently, referrals are to be faxed to us, and any inquiries can be made via phone or email. So now moving on to the Head to Health program. This is a fairly new program and was established in September 2020 in response to the COVID-19 pandemic and the impact that it's had on Victoria's mental health. So the Head to Health program consists of an intake service, which I'm part of, and Head to Health hubs. The Head to Health hubs offer treatment and intervention. So anyone can call the intake service. They will speak to a mental health clinician who will complete an assessment with them over the phone. We use the IAR tool. Based on the individual's needs, we will connect them with support and services. So that might include referring to one of the Head to Health hubs, to a Care in Mind service, or to another service. Clients can also contact one of the Head to Health hubs directly. The Head to Health hub will do the intake, and again, depending on the client's needs, we'll refer them to an appropriate service, whether that is at the hub or elsewhere. These are the contact details for the Head to Health program. As I mentioned, a big component of this program is the intake service. So the intake service can be contacted via the 1800 number. We are open Monday to Friday, 8:30 till 5. GPs, other health professionals and support services can also refer to the Head to Health program, and we often receive these types of referrals via fax or email. And of course, once we receive a referral, we will call clients and go through the same process as if a client was to call us directly, complete an assessment with them over the phone, and connect them with support. So our Head to Health hubs are located in Broadmeadows, Wyndham Vale and Brunswick. And they offer multidisciplinary evidence-based care that is integrated with existing services. Counselling and care coordination can be offered at the Head to Health hubs, and also referral to external supports if needed. So now moving on to the IAR tool. So as I mentioned before, this is the tool that we use at the intake point. And the purpose of the IAR tool is to gather information about the individual and determine what the next best steps are. So including what level of care is required. The purpose of the IAR tool is to increase efficiency and effectiveness of health services for consumers. So consumers are assessed and connected with services consistently. There are 8 domains in the IAR tool. So the first 4 domains are the primary domains and the second 4 are the contextual domains. Once we gather information about each domain, then we will score the domains, and we will then come to a level of care. So the level of care is a recommendation. experienced mental health clinicians complete the assessment. So obviously their clinical experience is very important in this process as well. And at this point we determine what support is available. So the levels of care are 1, 2, 3, 4 and 5. Level 1 and 2 involves self-management and digital supports. Level 3 and 4 requires more structured intervention, such as psychological intervention, care coordination. And level 5 requires acute or emergency services. So I thought I would include a couple of case examples to see how we actually apply the IAR. So I guess when we're talking to an individual, we're understanding why are they calling? Why do they think they need mental health support? What are some areas that they would like to address? And how do they think they could address those areas of concern? It's really important to engage individuals and get them involved in the process of accessing services, and obviously considering client choice and preferences. So Natalie is a 30-year-old female with worsening depression over the last few months, more frequent ups and downs, and increasing irritability. Natalie reports at times she just wants to give up as she's tired of her situation. She denies self-harm and suicidal ideation. She has a past history of self-harm and suicide attempts in her teenage years, and at this point she received support from Origin Youth Health. Her protective factors include her 2 young children, and she is help seeking. So she has called us. She's identified that she's not doing too well, and she's asking for help. Natalie is struggling to keep up with the housework. She reports she doesn't have any energy and just wants to sleep all day. She is managing to care for her children, get them to kinder and school, and prepare their meals. She reports increased alcohol use. So she states that she drinks wine each night, and that's increased over time. And she has a past history of smoking marijuana, but she hasn't smoked in many years and stopped when she was pregnant with her first child. So as I mentioned, Natalie did have some contact with Origin Youth Health during her teenage years. She had a couple of inpatient admissions and she found their support helpful. She's accessed many different psychologists over the years, but last time she saw a psychologist was quite some time ago. She is taking antidepressant medication and she's been on that for about a year, but she reports little effect. So Natalie is a single mum. She's living in private rental with her 2 young children, and there is ongoing conflict with her ex-partner, who is the father of her children. She reports trauma during her childhood. She felt unloved with minimal emotional support. She reports that she has limited supports. She does have a friend, but she doesn't want to burden them. So Natalie presents with good insight. It's easy to engage her over the phone. She's open and wants to seek help and shows a commitment to that. So in terms of the IAR and how we would apply this to this case, I'm sure many of you might have seen a similar case come through your clinic. So this is how I've scored Natalie's IAR. So you can see each domain there, and the overall level of care required for Natalie is a 3+. So obviously while I was scoring the domains, I was considering Natalie's symptoms, her level of distress, how long she's been experiencing these symptoms, how it's affecting her level of functioning, obviously any risk concerns. So Natalie reports that she is tired of her situation. She denies suicidal ideation or self-harm thoughts, but there is a past history. And her protective factor are her children. As mentioned, she does have limited support. She says that she has one friend, but she doesn't want to burden her. And in terms of social and environmental stresses, Natalie mentions ongoing conflict with her ex-partner, trauma experienced during childhood. So the IAR tool is a great tool because it looks at an individual holistically and gives us a nice picture in terms of what's going on for Natalie and what type of support she needs. Another case example. So Brian is a 45-year-old male who reports low mood, frustration and anger, difficulty sleeping and racing thoughts. Over the weekend, Brian phoned psych triage expressing suicidal ideation. He was visited by the CAT team over the weekend and then referred to Head to Health for ongoing support. He does have a past history of suicide attempts. His last attempt was last year, and brief hospital intervention was required at this point. His protective factors. So Brian has adult children who he is trying to reconnect with, and he's on the wait list for public housing. So he has some future planning there. Brian's main concern is that he finds it difficult to fall asleep and wakes several times during the night. His appetite is okay. He's been accessing food and meals through shelters. He enjoys catching the tram and the train, and he does this to distract himself. Obviously, COVID-19 and the lockdowns affected this. And Brian states that he really struggled during this time. Brian mentions alcoholism for 20 years, but he has been abstinent for 1.5 years. He reports some issues with his prostate, but he's not exactly sure what those issues are. He has accessed mental health services for many years. Starting when he was 18, he saw a psychiatrist and he thinks he was diagnosed with schizophrenia at that time. Brian is familiar with accessing services during crisis. He has been taking risperidone for many years. He's unsure if it's helpful. He's currently living in transitional accommodation. He's been there for 2 years. And as mentioned before, he's on the wait list for public housing. He reports very noisy neighbours, unpleasant environment. He's on the DSP and has been for many years. As mentioned, he would like to reconnect with his adult children. He is currently receiving support from a housing worker. He doesn't report any support from family or friends. He experiences loneliness and really values relationships. He's upset that he's finding it difficult to reconnect with his adult children. And of course, upset by his housing situation. So again, how do we apply the IAR to Brian? So it seems like Brian's main concerns are his housing situation, difficulty reconnecting with his children. And those factors are potentially affecting his sleep and his mood. There might be an underlying mental illness though, considering his history. So it might be worth Brian seeing a psychiatrist. His level of functioning seems not too bad, considering that he manages to get on the tram and the train and visit shelters to access food. But his sleep is a real concern. Brian mentions that he has limited support. Again, looking at all the different domains, that's going to affect the level of care required for Brian. So Brian does require level 4 plus support. So as I mentioned, it might benefit Brian seeing a psychologist to manage his emotions and speak to somebody about his current situation and how that impacts him. A psychiatrist, some care coordination work might possibly be needed, considering he does have a housing support worker. And this final slide provides kind of a summary on the different mental health services that are well known in the primary care space. And when do we refer to Better Access, Care in Mind, Head to Health? So as I mentioned, anyone can contact Head to Health. It's a great service because clients can just pick up the phone in the comfort of their own home. They don't need to visit their GP. They don't need a mental health treatment plan. And GPs can refer to this program as well. But we also have the wonderful Care in Mind service and the Better Access service for the people that can afford to pay the gap fee associated with each session. Okay, so that's it from me, but I'm sure you'll hear more from me later on during the panel. Thank you.
Thanks, Steph. Yeah, I've definitely got some questions about that for later, and that's just reminding you all to ask your questions in the chat. They'll come through to me, and I'll have a look at them and use that to stimulate the panel discussion. And I think. Yeah, I think any questions are a fair game, like just ask whatever you really want to know about, because this is a real opportunity to get those questions answered. And we're going to move on now to Jenny, who Jenny and I share quite a few patients. I've known her for quite a while working in this area. Jenny's been a psychologist since 1996. She has extensive experience working with adults throughout the lifespan with a range of issues, including anxiety, depression, suicidal ideation, grief, and trauma. Jenny works with a variety of support services such as TAC, WorkSafe, Victims of Crime. She is in the Care in Mind Targeted Psychological Services and the Care in Mind Suicide Prevention Service that you just heard Steph talk about. Jenny's main areas of therapeutic interest are trauma and women's anti and postnatal care. She uses various treatment modalities to customise a treatment plan for individuals to maximise positive change and support. I also know Jenny through the Mental Health Professionals Network, which she facilitates, and I don't think I'm speaking out of turn to give that a bit of a plug, because that's a really good way to network with local mental health professionals. It's held 4 times a year. And I attend, a lot of GPs attend, psychologists, social workers. So yeah, I'd really encourage you to join one of those coming up. So now I'll hand over to Jenny.
Thank you, Ben. And thanks for inviting me to talk about the private pathway of referrals to psychologists. So we've heard about the public system, and of course there's a private pathway as well. So most of you would be very familiar with this pathway and perhaps use it daily. But I just thought I would bring up a few issues and challenges and benefits in this area. And of course, one of the positives that's come out of the pandemic, we can claim this as something that hopefully will stay, is the 20 sessions per calendar year from January to December. Obviously, historically, it started off with 18 and then moved to 12 and then moved to 10, stayed at 10 for many, many years. And we needed a pandemic to show us that 10 really isn't enough. And now we've got the 6 + 4 + 10 model. And we've been told that we can have this till the end of this year. Hopefully with some lobbying and some feedback, we'll be able to continue this model. And of course, telehealth has been a big winner from the pandemic. We used to have telehealth just for regional areas, those who were not in Metro Melbourne, and now it's just opened it right up, and people can access psychologists from all around the place. And so it's obviously made access so much better, as well as better fits, you know. So if you've got a psychologist across town that really is a better fit for what you're seeking, well then, you know, hopefully there aren't as many barriers to get there. And telehealth has just been great. People have accessed it in their lunch hours. Students have accessed it at school without having to take time off school. And again, thankfully, with a lot of lobbying, we've been told that that's now a permanent fixture, which is great. Now, we would think that 20 sessions per calendar year is just all benefits, and of course, we wouldn't want it to go, but it does have its challenges as well. We've found after having this for a couple of years now. And the challenges can be, I think, a problem that's happening all the way around, which is access and just being able to manage to fit people in into the practice. So you imagine that you have people already started off on their 10 sessions, and generally they would stretch them out as much as they could through a calendar year and maybe get to about October and then hold tight till they get a fresh lot of 10 the next January. But now with 20, they will continue to do the valuable work that's needed. And it definitely isn't just a tea and tears talk. You know, we do some really valuable healing, lots of deep work, and people will say, oh, we'll continue to do that. They then hit their safety net, which is fantastic for them, and don't have much of an out-of-pocket fee. So they want to fit in their 20 before Christmas, and that is absolutely fair enough. But what's happening now is you've got this bottleneck between new clients who want to access the services, and COVID has unearthed quite a few issues, as well as then being loyal to your already existing clients. So I suppose it's a challenge that's all the way around public and private systems. But it really is difficult where you really want to help new people coming through, but also don't want to leave your existing clients without room for appointments. So a lot of what's happening, and also obviously for GP appointments, I'm sure you're finding the same, just managing appointments can be quite difficult, and trying to find a way to, you know, service as many people as possible, work with as many people as possible without burning out ourselves. So managing appointments, and not just saying yes to everybody because, you know, they can get in on one session but then can't rebook. And it really is quite a dissatisfying experience if they can't finish the work and feel supported. I think it's actually more dangerous than saying no. I think, we really have to be careful how we manage people's episodes of care. And of course, just a reminder to us all that for some reason, I think it was Tony Abbott, I might be wrong, but I think it was back then, he deemed that couples don't need to be under Medicare. So couples often come thinking that they have a subsidised session through a mental health treatment plan, and couples work is private and can be rebated through extras on private health, but not through Medicare. And that's quite disappointing, and I'm not sure whether we've got energy to lobby for that at the moment. It seems to have been like that for years and without much said. But COVID has definitely created relationship issues. Interestingly enough, we have had many couples on the brink of separation through different beliefs about the vaccine and just about how to go about the pandemic. And it really has strained many, many families and relationships. So I'd love to have that on the table if we feel like lobbying about that. Say your bit whenever you can. That would be great. So the right fit between client and therapist is really important. It's difficult in that we just need people to be accepted into some, practice or clinic. And at the moment, because of the demand, we sometimes don't think about the right fit between the client and the therapist. So obviously, it's really intimate work, honoured to be working with that person, and it needs to be a right fit in terms of that therapeutic alliance, as well as the therapist's specialty areas, expertise, experience, where they come from. And it's not just about, are they a health psychologist, clinical counselling psychologist. It really, I think, is about sort of where their skills fit in and how it can help the client. So this is where the importance of networking is paramount. And Ben just mentioned there about the mental health professional network. I've been coordinating the Hobsons Bay MHPN for about 15 years now, I think. The years roll on with my colleague Sergio, and we do meet 4 times a year, so February, May, August and November, and we would have a speaker and then time to network. We've continued through Zoom and hoping that it will be back face-to-face, because, we're talking about people. We're people. We need to connect. And Zoom gives us information, but I don't think it gives us that energy of connection, and it'd be great if we can be in the same room again. So we're all time poor, but in an ideal world, we would visit each other in practices and clinics and catch up and talk and get to know who we're referring to, put a face to a name, feel like, we're referring real people to real people. And again, we dream about having more time. Hopefully, if things settle down, we can start to do that networking face-to-face again. So Dean mentioned an episode of care, and I often talk about an episode of care to clients. So it's not about fixing everything. It's about, what are you here for right now? We do a thorough assessment as we are going through history and presenting problems. We're listening out for what we could do in this episode of care. And I'm always thinking, how can we benefit in 3 sessions. If we haven't grabbed the person in 3 sessions, they most likely won't come back. So what can they feel a change or a benefit or a connection within about 3 sessions? And of course, you know, the first referral is 6 sessions. And so I actually ask them about, you know, treatment goals, and we work on those together. An analogy is like you book your car in for a service. You don't say, right, I want everything fixed, everything done in this one go, thank you very much. You really do say, right, you know, this time it's going to be the tyres or this part of the engine, or, you know, so we can't hope to fix, you know, a lifetime sometimes of trauma within about 6 sessions. So we really need to be careful that we don't overpromise. So Ben asked me about some psychological approaches when we had a chat, and of course I'm not going to do any of these justice because you could be studying them for years and we never finished learning, always learning new techniques and you know, trying to work out what we can improve. But in a nutshell, psychoeducation goes a long way, just to let people know that often their symptoms and their presenting problems are in the very big range of normal, and giving them some psychoeducation, just, you know, information that puts their mind to rest. I've heard so many times, am I going crazy? And no, crazy is, you know, a very, very broad definition. So no, we assure people and they often can feel quite comforted. Trauma treatment, and that's the depth of work that we need 20 sessions for, using EMDR, you know, cognitive processing, many other different ways of treating trauma. And COVID has, you know, triggered a fair bit of childhood trauma, it seems, the isolation, feeling alone. It's amazing what's coming through. Behaviour activation, just that, you know, getting moving, just doing. And again, I think COVID has created a lot of feelings of being stuck, not knowing where to pick up, where we've left off. You know, I used to be part of this group, that group. I don't know if I can go back, don't know if it exists anymore. So I'm hearing a lot of people that are feeling flat and a bit lost. So trying to get that behaviour activation. Solution focused is very much, okay, what do we want to achieve perhaps in a few sessions? And some people are very happy with that approach. Schema therapy, looking more at patterns, at maladaptive negative beliefs, coping behaviours, and trying to work out, you know, how they have developed, and then of course trying to shift them. Internal family systems, very similar, looking at parts of personalities and again how they formed, what their function is and why they're there, and healing within the person's personality system. Of course, CBT approaches, looking at reframing and cognitive errors. Acceptance and commitment therapy, where we use, you know, quite a few strategies, mindfulness, values. And of course, clinical hypnosis, that could be used in all sorts of areas, gut work, yeah, all sorts of areas to get things moving. But every time I'm learning more and more about different models and therapies, I always come back to the therapeutic alliance. I think we can pull out strategy after strategy and model after model, but unless you connect with a person and they feel safe and they feel heard and they feel human and they feel like they're just not a number and just not a, you know, another piece of paper, another referral, that's when, you know, the most healing happens. So that's the private pathway in a nutshell, and I'll hope to add to the panel discussion later on. Thank you very much.
Thanks, Jenny. Now I'm going to invite the speakers to all come back. We're going to have a a chat about all these issues. Reminder again to keep sending the questions in through the chat function. And I think, Stephanie, you've got a couple of colleagues in the chat room answering all your questions for you.
That's great. Thanks, Sarah and George.
So I'm going to use one of the questions to sort of launch off on something that I wanted to ask too. It said, what are the current wait times for care in mind referrals? Can you talk to that?
Yeah, on average, it's about 4 to 6 weeks. Again, it depends. I think this was mentioned in the chat. It depends on where the client lives, what providers we have available in those areas, whether they're open to telehealth or not. And with the suicide prevention service, I think I mentioned, I hope I did, that the response time is a lot faster than the other Care in Mind programs. So.
Yeah, because that was actually one thing that I was going to get us to all talk about was telehealth, because I'd echo Jenny's thoughts that it's an amazing way to deliver care, and especially in a pandemic. But I think with those geographic restrictions that a lot of people have, and tailoring people's treatment to the right fit, being able to, I don't know if people know what supervision is. It's a term for, I don't know, psychologists use supervision. So it's talking to a mentor or someone that you choose about your practice and discussing cases. And I've actually done my supervision via telehealth even before the pandemic, and my supervisor's in Camberwell or something, so it would have been very difficult to do that. So I'd like to ask you all about how you found telehealth and what are some of the innovative ways that we might be able to use that. I know that Dean mentioned the workforce, that and there might be difficulties legally with some of these things, but whether telehealth and doctors and psychiatrists being off-site and providing things via services via telehealth might be either for now or for the future might be a good way to address some of these problems. Does anyone want to start with that?
Yeah, Ben, I might kick off. Pros and cons. We've been doing it for 2 years now, and we certainly haven't had more adverse incidents because of it. I think telehealth is no problem when you have an established therapeutic relationship with somebody and you've known the person for a while. You can pick up by the tone of their voice and how they're going. I have worries about new patients coming in with telehealth. And of course, there's different kinds of telehealth as well. If you're talking video, I think that's a step above. But in public mental health, not many of our consumers have that. They might have a mobile phone, but in terms of having a proper setup to do the video type telehealth is also a challenge. So that's our experience. It's worked. In some incidents not as well as we would have liked it to, but it hasn't been a disaster. So not sure what your experience was.
Oh, look, it is a mixed bag. Some people are still choosing to remain with telehealth because they don't want to wear a mask. So there's that problem. So once that moves on, maybe that'll change. It's quite a challenge for some kids and adolescents. You do see them glaze over, and sometimes you see the screen sort of flickers. You think, what else are they looking at? That's not happening when they're in your room. And obviously in your room, you've got different resources and hands-on things. So I do a lot of experiential work in the room. And so I find that telehealth is limited there. It really, does depend on whether you can just do that straight talking. But experiential work, I'd rather feel the energy in the room and be with them. So I have to be very cautious and careful. You don't want to just be switching off that screen and not sure, what's happening on the other end. But I would say over and above, you know, no system's going to be perfect. And it's definitely, I think, created more benefits than not. And, you know, when I think about the stretch of clients that I have now across Melbourne, yeah, it's great. You know, it just sort of means that perhaps people are getting more of what they need. Yeah.
Have you had much experience with telehealth?
Yeah, again, a very mixed bag. Sometimes we find clients who are presenting for mental health support for the first time are not too keen to utilise telehealth. It can be quite a unfamiliar space to step in, you know, when accessing mental health services for the first time. So we do get quite a few consumers who ask for face-to-face support. But again, in saying that, you know, telehealth has enabled, you know, greater access. So people who are, you know, in areas where there are limited options, they've been able to access a service sooner. And teenagers are very used to using social media and technology. So, yeah, it can be difficult engaging them via telehealth, but and obviously children.
Interesting. I have some clients that really open up just on the phone. I honestly never thought I would just do phone stuff. And of course, you've got Lifeline, all of that is on the phone. And some, you know, don't really want to face you sometimes and find the, just the privacy or the anonymity of being on the phone to be quite liberating. So it really just does depend on the person, the moment, the problem, the situation. And it'd be great if we have choice rather than, you know, it's got to be one or the other. So.
I think the benefit with telehealth too is that you're seeing the client in their home. You might see their interaction with their family or their partner, and so that brings another element to it. And also since COVID, because we were forced to use telehealth, there are quite a few psychology and psychiatry services that are purely based via telehealth now.
That's right. That's right.
So access to a psychiatrist is a lot easier for some.
Great. I think having a look at that flowchart and hearing from you all that because the system's so fragmented, I see communication as a real challenge and how to do that most effectively. I know we still use fax a lot. There's email, which is, you know, you've got security problems around that. And these secure messaging systems often don't talk well to each other. And then you've got the hospital system that has a very secure system, obviously, and difficulty with communication there. So just wondering what you all think about, you know, how, especially for GPs, you know, they have patients that they might send to the emergency department, they have an episode of crisis care or get seen in the emergency department and need to communicate back, you know, how we can better improve some of those communication systems.
The first thing that pops into my head is the My Health record.
Right, yeah.
I know we don't utilise that as much, but
not everyone's opted into that.
Yes, that's right, yeah. But I think that's just something that kind of pops into my head when I think about how we can communicate better with each other. But yeah, you're right. It's an opt-out, I believe, system. Yeah.
So that's I think still
not
quite
perfect,
running so well. Yeah. Jane, have you got any?
I'm a bit of a pessimist when it comes to this, I'm afraid. Is, you know, if you look across Melbourne, every area mental health service has its own EMR or doesn't have an EMR, which might be different to the hospital's EMR. So you've got multiple systems, and you know, I think we're a long way away from sorting that out. It would make sense that if there was one system that was rolled across the whole state, but that hasn't happened. And you know, services have invested an enormous amount of money in the electronic medical record systems. So it's unlikely that they're going to change. So yes,
it's very clunky at the moment.
It is, yeah.
I guess, that care coordination work probably comes in a bit maybe there too. We find that when we speak to consumers who have so many different services involved, care coordination work for them just makes a huge amount of difference. That they can have someone calling all the different services, asking about, what kind of support are you offering, what work are you doing with the individual at this point in time, and just, coming together and making sure that everyone's on the same page.
Okay, I've got some good juicy questions now. They're starting to come through. So, and a few of these were ones that I wanted to ask as well. So, now I'm not sure exactly who it's directed at. I've got an idea. What would you advise a GP who cannot get a patient into a psychologist or a psychiatrist and is not eligible for the public program?
Well, that's exactly why there was a Royal Commission, wasn't there? So there's so a lot of the recommendations coming from the Royal Commission are related to that particular problem, that missing middle. Where do they go? So there's nowhere for them to go now, but as the recommendations become implemented, there's going to be a lot more. There's going to be, as I mentioned, on local area mental health services, which don't have the threshold of clinical area mental health services. So those will be, drop-ins and easy access. And then if there's more complex care required, there'll be a referral through to area mental health services. But as I said, the timelines we don't know. So at this point in time, those gaps are still there. And I think the Head to Help might help with that at the moment, but there's only 3 of them.
Yeah, look, I think
hopefully there'll be more.
The good thing about the Head to Health program is that, yes, there are only 3 hubs in the northwestern Melbourne catchment, but there is an intake service, and our aim is to connect people with support. And if we can't do it straight away, we will tell the individual, we're not really sure at the moment what's available for you, but we'll get back to you. And so we will follow up and we'll make sure that they do get connected. And a hub is only one option. We've done a lot of work to understand referral pathways, to understand the mental health service sector. We've established really good relationships with other services like area mental health services and community-based services. So it's difficult for us to navigate at times, but I think we're doing a really good job as a team to try and understand the sector. That way we can support people in connecting to services. I'd like to mention also that there's the Partners in Wellbeing service, and recently mental health and wellbeing clinics were established through CoHealth, Mind, NEMI, I think a few other organisations, and I'm hoping that they're starting to fill that gap.
Sorry, what was that? What was that program?
So access is via the Partners in Wellbeing line, and they're called mental health and wellbeing clinics. And they're supposed to meet that gap. So there are things happening.
Those are the starts of the recommendations. So, you're starting to see these things coming online. So, next year things will be better, and the year after they'll be better. So,
are there any other Head to Health hubs
across the state?
No. Are there any sort of listed to open up in this Western Northern? Do we know?
Or
you can't say.
Yeah, look, we have a satellite hub in Melton.
Right. Okay.
But we're very aware that only 3 hubs in the northwest is not enough. And it's something that we're would love to have a hub. In most spots, but it's all about funding and
So I just didn't know if there was something in the pipeline yet, but
look, Head to Health is a statewide program, so there are hubs across the state and there are intake services.
I mentioned in the introduction about those what used to be the mental health community support services, and that were those NGOs like NEMI, Mind, CoHealth, Reach. Does anyone know what they're doing now? like you mentioned a couple of them actually, and how you can access the services, because they're great organisations.
They
and
are.
I'm sure they haven't just disappeared.
My understanding is that Mind, NEMI are big NDIS providers.
Yes, that's right. Yeah.
So it does make it tricky, because if you're not eligible for the NDIS, how do you access their support?
Yeah.
But they do have other mental health services available, my understanding is.
Yes. We do a lot of work with Mind and Co-Health at the moment, looking at partnerships, particularly around local area mental health services. So they're still very active.
I've got a question here about, it says, I'd forgotten that Head to Health exists. How is it publicised to GPs? And I also didn't know about it myself until I started doing this forum. So I'd also like to know how it's publicised.
Oh, goodness. Well,
you could hand it over to your bosses.
I'll say that May of last year, we asked Sarah Croker to come and speak to our mental health professional network, and she outlined the whole it was called Head to Help,
yes,
and then it became Head to Health. So for some reason there was a title change, and that's why we need to keep networking, just so we can.
Because things are changing really quickly.
And you lose track of what's funded, what's not, what's renamed, what's an acronym, and we don't have really the time to sometimes,
and what's state and what's Commonwealth.
That's right. So sometimes it is just depending on your colleagues to keep you up to date as well.
I think the Head to Health intake service is really good at, speaking to the community in general and providing an update with what's going on out there. I mean, we don't have the answers for everything, but I think it's a great service. And I do know that a lot of GPs do phone us and say, I've got a patient presenting like this, not sure where to go. I know there's, long waits to see a private psychologist. And we just kind of talk it through together. So that's one option for GPs to kind of understand what's going on in this ever-changing space. As I said, we don't have all the answers, but
I think last year we were getting emails about it. I mean, as a Care in Mind provider, I was on the email list. So, but I don't think there's been an email sort of about it for a while. So maybe, a bit of a refresher.
We do promote Head to Health and Care in Mind in our GP newsletter.
Okay.
So,
I suppose you also try to market direct to consumers or patients. Because you encourage self-referral, right?
Yeah, and that's the main way that Head to Health is actually being accessed, is through self-referral.
Okay. So is it social media?
Television ads or?
Social media is a big part, of the marketing. I'm not sure about TV. But,
do you have any links with Headspace? Like, do you talk to each other?
Absolutely. Yeah, absolutely. So as we know, Headspace are their services are in great demand. So we often talk to the Headspace centres in our catchment, understand what their capacity is like. If we can refer to them, can they refer to us?
I'll go through a couple of quick questions as well, but just before I forget, Dean, what do you see the time frame of the rollout of the Royal Commission recommendations? Is it sort of a 10-year thing? Or?
Yes, but I think it's a long-term project. So we're looking at 10 years to see all the recommendations being fulfilled. And of course, there needs to be, the government needs to maintain their commitment to continue funding. So one always worries if there's a change of government, is the commitment going to be the same as the government who initiated the Royal Commission? So, but there seems to be a general recognition that the services are desperate for money and reform. So, but it's a long-term project.
I hope the money's been put aside.
Yes, I mean we certainly we've never seen money flow into mental health as we have in the last 2 years. So it is certainly coming, which is great to see. Instead of clipping of budgets every financial year, we've seen this this burst of money, which is great.
And again, thanks to the pandemic, maybe, I'm not sure.
Maybe.
Steph, what's the age eligibility for Care in Mind and Head to Health?
There's any age across the lifespan. Yeah. I mean, obviously, when we're looking at the intensive support service, which is for severe mental illness, if we had a child that presented, we would, refer to RCH. Across the lifespan.
Now this is a complicated question, but a good one, and we can all jump in at different points. So, how do you know which services to use, Mercy Hospital or Care in Mind? What are the determinations?
So Mercy is an acute service.
Yeah. That's correct. Yeah.
So maybe the person that asked the question might sort of like to know, I guess, how they might determine the acuity. And I guess one way is to refer to your intake service, which will do all the work for them. And you'll use your IAR tool, and you might you do make referrals to Mercy if they're a certain level, right?
Yeah. Absolutely. We do refer to psych triage. We don't get many level 5s, but we have definitely had to call ambulances before.
Yeah.
And psych triage has referred to us.
Yeah, that's right. That's right. There's a two-way street. Yeah. I think at this point in time, area mental health services manage acute and severe enduring mental illness. So our business is severe schizophrenia, bipolar disorder, severe depressions, psychotic depressions, severe personality disorders, particularly borderline personality disorder. So that tends to be, and unfortunately over the years, as services become more and more restricted and the thresholds have become higher and higher, which has been awful. But that's what's happened, because there just hasn't been the funding available to provide the services that we used to, and that's why there was a Royal Commission.
Yeah. This links a bit to my communication question, but because I can see that GPs, if they think it's quite a severe problem, I'd encourage them to call triage. But has there been consideration to having, say, a health professionals triage line? Because sometimes I will call triage and sort of wait on the phone and then wait for a call back, and then you've got to see other patients, and I'm sure GPs are needing to move on to the next patient.
Resources, Ben, that's it would be too expensive to run something like that. Triage services have been overwhelmed. We have 2 clinicians on 24 hours a day, and that's still not enough. As you say, your experiences, you go through to an answering service, and then you might get a call half an hour later or 2 hours later. We're hoping to see, as the local area mental health services come in, that the demand on triage services will decrease, because referrals to area mental health services will only be through general practitioners, psychiatrists, and the local area mental health service. So that will narrow quite significantly the referral base. So I think we should see improvements in a couple of years' time.
I've got a question here. We are seeing a patient in the community whose behaviour is escalating. They have no self-awareness and are not seeking help. They may hit a crisis and require hospitalisation. What can we do to prevent this? So, I think what we just talked about with calling triage is obviously the call here, and you can call an ambulance or 000 if required. Right. Or you can, I think if they've got no awareness and don't want to seek help, they're not going to self-present to the hospital. But I guess for example, if you use the IAR tool, and then they're going to be at a higher level, right?
Yeah, look, I think at the end of the day, it comes down to risk. If someone's not willing to engage in mental health support, they have a right to do that. However, if their level of risk is high, that's when area mental health can step in. Look, unfortunately, there are a lot of unwell people in the community who lack insight and don't want to access mental health services. it's really difficult. It's very difficult for a GP. I can't imagine what it would be like trying to support that person. But yeah, at the end of the day, it does come down to risk and doing a thorough risk assessment.
And of course, that's where the Mental Health Act steps in. So, you know, if the person, as you say, is high risk to themselves and others, and is likely to deteriorate, and then one has to consider the Mental Health Act in terms of facilitating treatment.
From my understanding, there were when I was still working at St Vincent's Hospital, they had set up a special team that was a suicide prevention or very high risk of suicide. What's the current? Hope. That's it. What's the current state of that service?
Well, that's been
the
very
state?
well. It's been rolled across the state. We have an active team. There's been more funding coming to that team, and that team's growing. So the team works from the emergency department, where they then pick up referrals and then follow the referrals up for up to 3 months. So that's been a great success.
Yeah. Okay. Any tips on what supports can be offered to patients while awaiting psychology or psychiatry referrals? Wait times are incredibly long at the moment. I think we were talking about this earlier.
Yeah. I mean, I mentioned partners in wellbeing. I think the digital mental health space has just exploded, and there are so many wonderful resources online. There are lots of helplines. We do refer many people to the digital resources. Again, it depends on their presentation, their level of engagement, but I would encourage directing people to those digital resources. I know Origin have a program called Most, and young people can access that online. It's a kind of an expanding space.
The other thing too, Ben, is we shouldn't forget the very important role that general practitioners have in holding the person as well. So they might, you might have to wait 3 or 4 months to get a psychiatrist appointment. But with regular contact with the general practitioner, there is that holding function which can be very supportive to the patient while they wait for that. So I don't think we should take that away from the role of GPs, that I've got to send the person to the psychiatrist. Yes, they may well need a psychiatrist review, but in the interim, that support that the GP providing that regular contact is very important.
Yeah, and I think sometimes GPs underestimate their role in that, and they think, I'm not really doing anything, I'm not a specialist, but just that regular contact. And someone that's caring and listening to them. And that, Jenny, I think we were talking about this was how do we make it it's not really a moral thing, it's, you and I both have sort of full books, and do we kind of give our best service to our existing clients, or do we kind of open up referrals and sort of reduce the amount of work that we're doing but service a greater number of people? I think it's a very hard question to answer. But
I just think that the numbers just don't meet. It is. It's a sort of a moral dilemma. It's a professional development dilemma. For me, it's a personal dilemma. I'm pretty bad with boundaries and need my sort of front desk receptionist, practice manager to say no for me, because I think in this helping profession you do want to help as many people as possible. But you do run the risk of shortchanging yourself as well as others. So you rather do good quality work, be realistic about what you can do. But I think, quite a few colleagues, started the year, myself included, sometimes thinking, another year going uphill, not really feeling too refreshed. It's, a heavy space. Not just the pandemic, but everything that's going on, in the world. And so, there's a lot of affected people. So I think, you do feel like you want to maintain your loyalty to your existing clients, but see, there may be a dependency there. Maybe we need to try and you know, get them to self-manage a bit more, and, you know, have a break from therapy. See how they go. They would surprise themselves often and give a chance for some new people. I have some lovely clients that will often say, look, I'm doing okay, I'd love the session, but if you've got someone else who's in more need, please give it to them.
Yeah.
And they almost feel guilty for having the session, but they're, you know, they're just as worthy. So people in the community are aware that others are hurting as well. Yeah.
And, you know, I think clients don't realise how resilient they are until it's, you know, mentioned. And social isolation is a huge issue. And, you know, so many consumers who are depressed, they are isolated. They don't have a support network. And so I think peer support is huge and can be, you know, really beneficial. You know, VMIAC have a check-in program where a peer support worker can call a client. So, yeah, it's not all about clinical mental health services, I think. Sometimes it's thinking about, you know.
And groups. So I've been thinking a lot about, you know, groups. There's a, you know, OCD group over in Camberwell for young people, and then there's grief groups and, you know, out-of-fic do anxiety support. So, you know, sometimes it's just enough just to be with others.
I think people that are lucky enough to have private health insurance can also actually access group programs at some of the bigger private hospitals.
Yeah, and day programs.
Day programs, yeah. And I've got a question here. Any tips for accessing private psychiatry support? I'm finding waiting times of 3 to 6 months, often 6. So I can talk to that first. So there's a few things. For example, like my books have been closed and I just didn't know when I was going to be able to open them again. So I didn't have a waiting list because I didn't want people to sort of be waiting on there thinking that it's imminent. I had a list of psychiatrists that I'd worked with before that I would recommend, and I'd give that. I'd give the triage number. I'll now give Head to Health. Head to Health. And I'd also ask them to contact the big hospitals like the Melbourne Clinic, Albert Road Clinic, Delmont, Epworth, Camberwell. Then you've got Wyndham Clinic in Werribee, because they'll have an intake service, and if private psychiatrists are taking new patients, they'll direct those referrals there. But also I think, and you might have to get the patient to do this, is rechecking in, because I've just sort of told my receptionist I can take a few more patients. And unfortunately, it's not exactly fair because there was no sort of line, but patients that happen to refer now, I'm sort of considering them. So I think checking back in with psychiatrists regularly, and I think that is something that if the patient is good at advocating for themselves, or you can empower them to do that, I think checking in again is a good way to do that. Anyone else got any ideas about the waiting times for psychiatrists? And I'd say for psychologists is the same.
I mean, as I mentioned, since COVID, there has been an increase in psychology and psychiatry via telehealth. And I'm sure that's, you know, improved access for some people. It's, you know, it's not an option for them. But I guess psychiatry is a specialty, and if we think about accessing specialists in general, there is usually a wait, unfortunately.
And it's difficult because if you don't close your books at some stage and your wait time just really balloons out to, you know, 2-3 months, we find that people book in, but they might book in at multiple clinics, and then they'll see where they can get in first, and then they'll come back and say, oh, look, I've found someone sooner, don't need to see, which is fine, absolutely fine. And in fact, we think, great, we've got some spots. But it really can be difficult to manage as well. So there's no point in saying to someone, you know, book in June, even because our books are closed. Well, our appointments, you know, are to the end of May, and that's just with existing clients. So I don't know if there's a real magical answer.
No.
We're still working it out, everyone.
That's right.
I mean, there are community health centres that do have counselling programs, and I think sometimes we forget that they are available, they're free or low cost, and they might not have psychologists. But, you know, we can explore that with clients and ask them if they're willing to give that a go while they're on a wait list.
Stephanie, what's the capacity for Head to Health? What's the average phone wait time and time to speak to the patient? Headspace has an incredibly long wait, so suggesting a GP to refer to Headspace is not actually much help.
So is that in terms of the intake?
Yeah. So I think maybe with the phone wait time, it might be like how long do people have to wait on the phone?
So there is an option to leave a message if a clinician is not available. Look, you know, as I mentioned, Head to Health is a statewide service, and the intake services are slightly different across the state. I can only speak to our intake service. We've got an amazing team. We often return missed calls within the day. So, yeah, there's not much wait, but that might change very soon.
What support services are available for patients with eating disorders? I struggle to find psychologists and psychiatrists for these patients, often aged 18 to 35 years old or younger.
Okay, so there is the Butterfly Foundation. That's a great resource. I would highly recommend GPs go on their website. There's also Eating Disorders Victoria. So I think possibly accessing those resources first. We know that people with a diagnosed eating disorder can access up to 40 sessions through Better Access, but again, it's hard finding a clinician that has that specialty. So
I've got another, this is related to the other question as well. There's a great website, it's actually run by the College of Psychiatrists, which is Your Health in Mind, and it's it's got a lot of resources and information there, but it's also got a directory of all psychiatrists, and you can actually search by age group, what their interest is, where they're located, whether they do telehealth. So you've got all these filters that you can put in there. I'd really recommend people get on there. I was actually contacted by a friend who asked me, oh, what do I do about this friend of a friend? And I actually just used the website and looked up.
We use that
website
all the time, and the APS have a similar function on their website. There's also Psychology Today, which is a bit of a service navigation tool. There's Ask Izzy. There's actually a few. There's Health Direct. But again, because there are so many, so sometimes that does create an issue, doesn't it? Because it's like, where do you start? And
I think another way sometimes that you can get lucky getting into a psychiatrist or psychologist is if they're just started their private practice, and it's hard to know who they are, but I guess that I think getting patients to do some of the legwork themselves really is good for them, and
absolutely,
and obviously GPs can't be doing that all the time. Where do Black Dog, Beyond Blue and similar organisations fit? Like, my first thought is that they're more about awareness and health promotion and advocating and lobbying government. What else do you think?
I mean, they've got loads of resources on their website.
Fact sheets. Also, you know, where to go. They suggest a few things. Yeah, I think it's more of a resource base.
I mean, Beyond Blue do have a helpline.
Yeah.
And a chat function, I believe, on their website.
I don't know if Headspace still has it, but they have a chat function,
Yeah,
like a type
eHeadspace.
eHeadspace.
Yeah.
So that's another option for young people.
Mm.
Might go for the last question now. Any creative ideas for creating new structures or groups that can increase public health response outside the medical model?
Well, I think that's happening. I didn't talk much to it during my section, but if you have a look at the shift in mental health service provision that will occur based on the Royal Commission recommendations, is that there's definitely a move from that clinical medical model to a more biopsychosocial model, and we're certainly seeing the voices of community services and lived experience people becoming very strong in what their needs are. So that's certainly happening. And I think you'll see a very different kind of approach in a couple of years' time. I mean, there's the expectation that we also provide the specialised area of mental health services, start providing a package of services rather than, all right, so you have schizophrenia, so you're psychotic, so here's your depot and go home and we'll see you in a month's time. So there's a strong shift away from that. So that is, I'm feeling quite confident that in a year or two's time we will see a lot more psychosocial treatments available to people. So I'm very positive about that. Yeah.
Okay, so I'm going to wrap it up there. Thanks everyone for attending tonight and taking the time out of your evening. We also have 4 more of these forums occurring. Information is on the website. And I'm really excited about those forums. Some great topics and really good speakers. And we're going to have some great discussions. While it's aimed at members of the public, I think I'm really looking forward to it. So I think it's really suitable for health professionals as well.
Thanks so much, Ben. Thanks everyone for attending this evening. We hope you found this session helpful and insightful, and thanks to our wonderful panel this evening who have walked us through some of the complex areas of navigating the mental health system. As Ben said, we have more forums coming up. We have the next one on the 24th of March. It's going to be in person and online. And you can click on a link in the setting, the page that you're in now, and you can book online for any of those upcoming 4 sessions. So those sessions, as Ben said, are for anyone. They are open to anyone in the general public, including clinicians. So we would love to see you online or in person at one of those sessions. There's a post-event survey. We'd love to get your feedback. It's going to be posted in the chat now as I speak. So please take a couple of minutes if you can just to click on that link and give us your feedback, which will help to shape our future forums. So the slides is the other question that's come up, and there'll be an email that will be sent to all registered attendees tomorrow, and all of those slides will be made available to you. So thank you so much for attending this evening. We hope you found it a really useful evening, and we look forward to seeing you at the next one. Thanks again.